Thank you very much. Thank you, Dr. Rajiv, and the scientific committee for giving me this opportunity to speak on the PG orientation course for the freshers. My voice is clear?
Yes, yes, very much.
Yes, sir. Go
Okay.
ahead.
So the specular microscopy, I'll be speaking about the specular microscopy. And I think I need to just give a very simple description of what it is, because this is not a very useful tool, especially in the PG days. When you look, when you go into deep into the cornea, or you're taking cornea as a specialty, probably you may need it at a later stage. Uh, so it's not moving, sir. Slide.
So just click on that.
Yeah. So what is specular microscopy, or what is it doing? So as you know, and most of us know, like the cornea is, we have been taught that cornea has got 5 layers, starting from epithelium, followed by the Bowman's membrane, followed by stroma. Then you have the descemet membrane with the endothelium on the inner side. And recently it has been described a pre-descemet layer, or the Duas layer also. So when you image a so I think Rajiv sir can move the slides. It is taking time when I'm clicking from here. Okay. Okay. So this is an image, an anterior segment OCT image of the cornea, where you can see where you can actually delineate few layers, like epithelium. You can delineate the Bowman's membrane. You can delineate the stroma. But when it comes to the posterior aspect, what we normally say is descemet membrane with the endothelium. We cannot actually show the endothelium. Show the endothelial cells or the details of the endothelium. So in this slide, when we examine the patient on a, yes, so you can take the next slides, no problem. So when you examine the patient on the slit lamp biomicroscopy, there is something called as the specular examination technique, in which you keep the observer system viewing part and the illumination part at 45 degrees from the central normal, and you try to get the reflection from the posterior aspect or the descemet membrane, or getting the few tips about how the endothelium is looking like. Here the problem is the increased backscattering from the anterior stroma, or especially if there is corneal edema or some other anterior pathology, the light gets scattered and you don't get a clear image. When the slit is narrow, you get a better image, but the smaller field. But when you have a wider slit, the larger field, but less clarity and less resolution. Next slide, sir. So this is another method by which you can actually check the endothelial status. That is the retroillumination method on the slit lamp I'm saying. So on the left side, you can see a case of Fuchs dystrophy with lattice in the stroma. And on the right side, you can see that fine dot things, which is actually early guttate changes in an early Fuchs. But again, in slit lamp microscopy, you can see this only in a very minute form. You cannot magnify it and you cannot record it. So that's where the principle or the importance of the specular microscopy is coming. So you can run that slides, click the buttons. Yeah. So when a light is coming onto the cornea from the sides, a few beams actually gets transmitted into the cornea, into the anterior chamber. Some gets reflected from the outer surface and some gets reflected from the innermost surface, that is the endothelial layer. There is a difference in the refractive index between the endothelial layer as well as and the aqueous layer. So that difference in the endothelial layer with the aqueous layer is causing the reflection, and that is being captured by a imaging system and being projected with a projected as a printout. So this is the basic principle of specular microscopy, and it has got a imaging system as well as an illumination system that is separated at different angles. And so you can run that video. This is how it is being recorded. You can keep your chin and the forehead just like what you do in a slit lamp examination, and just focus at the center point of the pupil. Then automatically it records and calculates and give you the printed record. It's quite easy and very simple, less time consuming. Next slide, sir. So there are different models available. No financial interest, Topcon, Tommy, Nidec, Conan. These are the major companies that produces the specular microscopy that is available in the market. There are contact methods. Contact method as well as the non-contact methods that is available. And the non-contact method or the non-invasive methods are more common one that we use clinically. And this is a picture of an eye bank specular. Eye bank specular, what you do is you have a corneal button in the MK media or the whichever the preservative medium is there, and you keep that bottle on the in the area you can see in the specified for that. And just like the normal clinical specular microscopy, the computer captures the various qualitative and quantitative measures of the endothelial cells. So the clinical, next slide, sir. And the clinical utility other than the eye bank utility are the studying various endothelial dystrophies, studying the posterior corneal surface. It gives us the details of the pachymetry. It helps us in planning the intraocular surgeries like cataract surgeries in some difficult conditions, and the ICL surgery, that is the refractive lens-based refractive surgeries. It guides the decision making in and the timing in doing endothelial keratoplasty as well as the penetrating keratoplasties. It helps in monitoring the patient sequentially in a post-keratoplastic eye. It helps in studying certain abnormal inclusion bodies, and which is useful in clinical as well as the research purposes, and also help in determining certain physiological changes in the cornea. So this is a normal endothelial cell morphology, which you might have learned that it's a six-sided hexagonal cell, which is arranged in a mono layer, in a single layer on the inner aspect of the descemet membrane. The cells will be in the specular microscopy. Normally, you see the cells as a white colored and with the margins or the borders in the black in color. And it also gives this picture also gives an idea of the surface of the posterior aspect of the cornea or the descemet membrane, whether it is smooth or irregular. Next slide. And just on the left side, you can see that the poor image quality. So previous slide, can you just show the previous slide? Sorry. On the left side, you can see that this it's a picture demonstration of the poor image quality. That is very important because when there is too much light or too much backscattering from the anterior stroma, the quality of the cells seen, of the endothelial cell seen will be very poor. And that actually gives the errors in calculating the cell count on the other details. So the image quality is also very important. So the major aspects of the analysis is divided into the qualitative as well as the quantitative. In the qualitative, you look at the size of the cell, the shape of the cell, the pattern in which it is being laid out, the cell boundaries, the Gettate changes, as well as certain other, most of us know only the Gettate changes. There are certain other inter or intracellular bodies of blood that has been described. And in the quantitative aspect, you look at the cell area, the cell density, and two other important features, that is coefficient of variation as well as the percentage of the hexagonal cells. I'll just brush through the important features. So this is a classic printout that you get with the pictures of the cells as well as the details. In the details, so next slide, sir. In the details, when you look at the quantitative data, you look at the printout. That is first what we actually look for, the quantitative data. So first and foremost is the patient ID, date, as well as the eye, like what we normally do for any other investigation. You have to confirm that you are looking at the right person and right eye. Then you look at the number of cells. It's the number of cells studied should be more than 100. If it is not more than 100, you cannot actually take that printout or that study as a reliable one, because less number of cells do not actually represent the actual condition of the cornea. So you just see whether the number of cells is more than 100. In this case, it is actually, I don't know whether you can see, it's 130. So it is taken as a reliable or a good quality image. And next comes the important features like the minimum size of the cell, the maximum size of the cell, the average size of the cell. Then it gives a standard deviation, The CV is the coefficient of variation and percentage of the hexagonal cells. So we'll come into the detail, and the cell density. We'll come into the details in the next slide. And next one, we have a histogram representation of the percentage. You can see the number of cells of each percentage of hexagonality is being shown in the histogram. How this is being calculated? It is being calculated either by two methods. One is called a fixed frame analysis, where you can see that the a fixed size frame is previous one. A fixed size frame is utilized to calculate the number of cells, whereas in the various frame, what they do in the fixed size, you can see that the edge cells, which is half, sometimes may be disqualified and they may not be taken into calculation. Whereas in the variable size, you actually go through the margins of the cell and you take an area and count the cells within that area. It can be either center method or a corner method. Center method is like, you can see this nucleus which I have marked. From nucleus to nucleus they count, whereas the corner method, you take the cell corners as the criteria. And most of the cases they have automated method. In some cases you can do a semi-automated method. You can mark the cells to be counted, and the machine will count the areas in which you have marked. Next slide, sir. And this is the endothelial cell count. You can click once more, sir. Endothelial cell counts at various ages. We all know that at birth, it is at maximum more than 3,500 cells. By middle age, it comes to around 2,500. Then at old age, 2,000. And there is something called minimal accepted. That is something between 1,200 to 1,500. If it is less than the critical value, that is 750, or in some books, it is 500. Any sort of surgery may be very catastrophic. And when you look at the cells, when you have around 2,000, 2,500 cells, you see the appearance, it's tightly packed, clean and smooth. But when the cells decreases, you know the endothelial cells doesn't multiply. So the available cells actually spread out and try to cover the cells that are lost. So when it comes to 500 cells, you see from the 2,000 to 500, you can see that the cell size is increasing. It's losing its characteristic hexagonal shape, and it's trying to fill up the space that has been lost by the dead cells. And in the quantitative data, so next slide, sir. Next slide. So in the quantitative data, two most important characteristic is, one is the CV, that is the coefficient of variation. I think many parts of the slides have been not being projected properly. I'm sorry about it. My internet connection got some problem just now, so that's why Rajiv sir is sharing it from there. So the most important one is the hexagonal percentage of hexagonal cells. When the percentage of hexagonal cells are becoming less, that is called the pleomorphism. When the percentage of hexagonal cells are more, that shows that the endothelial cells are more healthy. When the percentage of hexagonal cells are less, that means the cells, many cells are being lost, and the other remaining cells are trying to make up for the lost cells. That is the pleomorphism, one of the most common term which you will learn or hear when you study specular microscopy. Next is the polymegathism. Polymegathism is the variation in the cell size, the coefficient of variation. Normally, it will be something around 20 to 30. In the printout, you will see 21, 22, something value about 20 to 30. Anything more than 30, 40, 50 shows that the cell is more poor in endothelial function. So these two are the most sensitive. We always look at the cell count, that you have 2,000 cells or 1,500 cells or 2,500 cells. More than that, you have to look at the percentage of the hexagonal cells, which should be a higher value. And the next important is the CV, which should be a lower value. These two indicate that the endothelial function is doing fine. Next slide, sir. One more, sir. Once more. So these are the whatever which we have described so far are the quantitative data that is provided by the machine. But the qualitative data, actually the machine doesn't give you much about a qualitative data. That you have to, the clinician or the technician should be experienced in picking out the certain qualitative data. Again, the most important is the size of the size and shape of the cell, and you can see that the borders of the cells actually classically it is termed as 120 degrees apart, all these. So you have to look at the various cells, you have to look at the various frames that has been collected and see how the cells have been arranged on the posterior aspect of the Descemet membrane. Next slide, sir. So the most important which we always look for is the guttate changes. So what is a guttate change? It is actually an excrescence from the Descemet membrane that comes through the gaps in the endothelial cells. So you can see such changes on the first left picture. You can see this can be a early Fuchs syndrome, or when you're seeing it at a periphery, it could be something called a Hassel-Henle bodies, which can be seen with the old age or in otherwise in a normal eye also. But when it comes to the center, and when it comes in the center picture, you can see there are a lot of them, and apart from that, the surrounding cells, in the first picture the surrounding cells are looking almost normal, but in the central picture you can see the surrounding cells are also abnormal. So it is so can you click once more? So you can see it's like your CN, no sir, previous picture. CNVM, it is coming like a mushroom between the cells. It's not coming inside the cell, it's between the cells, mushroom, and the cells, the endothelial cells are actually getting damaged. So when it is increasing, and this mushroom actually burst out, and you can see in the last advanced picture of the Fuchs, inside the guttate changes, you can say the center, you can see one white dot. So these are the three stages. These are the initial stage. Then you see the in the central part, you can see those increasing with the surrounding cells getting damaged. And in the last stage, you can see that the center, again, a white spot comes. So these are the various stages of the guttate changes that you see in the Fuchs dystrophy. Next slide, sir. Apart from that, there are a few other bodies or inclusion bodies you can see. You can, in the left, you can see the bleb or the vacuole, which is inside the cell. You have to identify this as separate from the guttate changes. The guttate changes won't look like this. These cells, these blebs, you can see inside the cell. You can see the margins of the cell very clearly. On the right side, you can see very fine black dots inside the cell. These are called the cilia of the endothelial cells. And on the left side below, you can see a white marks on inside the cell on the various parts of the cell. This is the nucleus of the endothelial cells. Next slide, sir. You can go to the next slide, sir. And another important finding, again, you can see some white patches inside the cell and at the various aspects. These are called the endothelial stress signs. These are the white deposits which are seen on the surface of the. We can see in the post-contact lens usages and post-surgical and post-keratoplasty cases. Next slide. You can see the elongated cells, which can happen when the cornea is little elongated, like it follows the size and shape of the cornea. Like such elongated cells are very common in endothelium of the keratoconus patients. You can see two blebs inside that one cell. Next slide, sir. These are the Descemet folds. We can see that the Descemet folds with the shadows by the side. Next slide, sir. And you can see the poor quality image and very unclear white spots all across. And these are actually artifacts. So you need to learn which are the artifacts, which are the actual. And this comes, as I said, this comes from experience only. And the one person who is looking after the technician or the clinician who looks after the specular for a long time regularly, you will only understand this. Otherwise, you look only at the quantitative data that is being given by the printout. Next slide, sir. These are the inflammatory cells. On the right side, you can see a herpetic endotheliitis. You can see the keratic precipitates, and these are in specular microscopy. These are seen as black deposits between the cells, not on the endothelial cells, but in the intercellular spaces. Next slide, sir. Another important syndrome, like a fugue syndrome, what we look is an ICE syndrome or a Chandler syndrome. Here, one important finding is the reversal pattern. Or as we say, initially we told that the cells appear as white and the margins appear as black. In Chandler syndrome, what we see is the cells appear as white, black, and the margins appear as black. This classical finding of the reversal pattern is because of the large pleomorphic cell. It is seen in the ICE syndrome or the Chandler's syndrome. Next slide, sir. And another classical finding is in the posterior polymorphous corneal dystrophy, where you see a round circumscribed vesicles. These are called as vesicles. There may be a collection of a group of vesicles individually or a group of vesicles, and you can see that a tram track appearance with the scalloped margins in the slit lamp, and similar appearances can be made out in the slit lamp on the specular microscopies also. Next slide, sir. So apart from this, various findings, there are some pitfalls, like there is a reflection from the stromal edema or the stromal opacities, and the backscattering can affect the quality of the image. The non-contact method gives a lesser magnification and resolution. The contact methods are not used in a clinical setup. Exact point of examination is not clear. You have to take multiple images, 3 or 4 images, and they are less reproducible. You cannot take the same area again and again because it's less reproducible. And lack of the specific findings to diagnose a disease. You have a few findings, but you cannot say that this particular finding is a classical of a pathognomonic of a disease. So a clinical correlation is important, and the experience of the clinician or the technician is very important. The anterior surface diseases prevents a good capture. These are the some few pitfalls in this investigation modality. And to summary, this is actually helps to study the endothelial cells both in the health and the disease in vivo as well as in the eye bank. Both qualitative and the quantitative evaluation is possible. You can get a pictorial documentation and print out to explain it to the patient, or for the medical legal reasons if you want to keep it. But the reproducibility of the investigation is questionable. But there is a lot of scope for research and refinements. Thank you. I'm very sorry about the poor quality of my presentation because last minute, because of heavy rains here, my internet connection got lost. And Rajiv sir, thank you for helping me in the last minute.
No, no,